Yeah. Good afternoon to all the participants of the webinar. I, Dr. Anil Managutti, Professor, and I request all the participants to mute the audio. So I would like to introduce today's speaker. Yeah. Sorry for the interruption. I request all the participants to mute the audio. Good afternoon and welcome all the participants to the Basic Oral Surgical Skills webinar series number 3. So the most eminent and energetic speaker for today's webinar is Dr. Dipesh Rao. He is a dually qualified maxillofacial surgeon with a degrees in both medicine and dentistry. He completed his graduation in oral and maxillofacial surgery, one of the esteemed institute of India, SDM Dharwad. Later on, he joined Dr. Krishnamurthy and he did a 1-year fellowship in cleft lip and palate surgery in Bhagwan Mahavir Jain Hospital, Bangalore. Then after this, once he completed, then his quest for the study, it did not complete. He started his MBBS in 2011 at Rajeshwari Medical College and Hospital because he wanted to become a craniofacial surgeon. Then he did, after that MBBS, he did the International Board of Oral and Maxillofacial Surgery. He appeared and he cleared. Then he went for a fellowship in Hanover, Germany in June 2017. Later on, he did a pediatric maxillofacial surgery position in fellowship in Australia, that is the Royal Children's Hospital, Melbourne.
Hello? Hello? Am I audible? Because I can't hear you, sir.
Yes, sir. You are audible, sir.
Right. Hi. Can I start? Is that my cue to start?
Okay,
I think,
sir. You can start, sir.
I think we lost Anil, sir, right?
Yeah, yes, sir.
I'll wait for him to come back online then. Okay. Hello, sir. Yes, sir. Okay. You went offline, is it? Okay. Okay, fine, no problem. Oh, okay. Yeah, one minute. I can do that then. Okay, I'll do that now. Yeah, I can see Anil is back online. So can we start? I think we can start now. Hello.
Please
Yeah.
start. Please
Right.
start.
Okay. Thank you so much. I'd first like to thank the organizers, especially Anil sir, for giving this opportunity to speak again for his participants. Um, it's been a long journey. It's something that is very close to my heart when I speak about medical emergencies or medical challenges that is there in the dental setting. Mainly because I have a slight advantage here because I've done all that is required in dentistry, and I've also done a full 6-year medical degree. Uh, it is not essential for all of us to actually do both the degrees. I mean, I know there is a lot of talk about bridge courses, and there is some amount of excitement that exists in most people think about, whether a dual qualification is absolutely essential, um, or a bridge course will help us understand things better. But I personally feel, you know, irrespective of what your qualification is, whether it is just a dentist position or an MDS position, um, knowledge is something that can always be gained, and it has to be gained. It is a continuous process. It is not something that can be done. Our minds are very volatile. We forget very easily, so we kind of have to keep in touch with the subject every now and then. Especially once you start becoming practitioner, there'll be so many situations where we will find challenges, especially related to the medical field, where there are so many drugs given to the patient. I'm not going to overload everybody with how you can treat an emergency in the dental clinic. That would not be an ideal presentation, because it's very difficult. We all live in areas with different resources. We might not have all the facilities in the clinic to be able to handle the medical emergency. I'm sure there are some students here, so they might be able to use them as their a learning point for their exams. But I'm almost always more inclined on sharing knowledge for practice, so it should be more practical. So when you are in your in your own clinics in future, you should be able to apply this in your practice. So what is a challenge in any situation, irrespective of um, whether it is your medical emergency or dentistry or anything, for your even for your regular life situation? What is a challenge? I think challenge is lack of preparedness. If you're not prepared, everything seems challenging. If Whereas if you're prepared, if you know it, then it is an easy job. It is like a cakewalk. If I ask you to write your name, for instance, you would be able to do that because you've been doing that for years and you know exactly how to spell your name. But if I give you a complicated spelling, you will not be able to do it, because one, the pronunciation of it would be for the first time that you would have heard it. And second, you're not spelling bee competition. So it is going to be difficult in that sense. So that again becomes a challenging prospect. So everything that you're not prepared for is a challenge. And I think preparedness is the answer for everything. This is a slide from a business management talk where they say the 4 steps to disaster preparedness is to identify the risk, develop a plan, implement and train, and be a leader in your community. Now, be a leader. This is such a profound, step. It's a 4-step guide to be a leader in your community. So when we talk about being a leader, it does not mean just to be someone in a commanding position. It is in your own practice, in your own place, wherever you are your own boss. Sometimes you might be working for a bigger clinic and where there might be other specialists involved, or you might be the only person running the clinic. So you're the boss, you're the leader of that clinic. So you will have to have all these steps of disaster preparedness so that you can then lead by example. So I will try and through this lecture highlight a few things that you might not be able, not just prepare yourself, but how you can prepare your receptionist, your nurse, or a dental assistant. Everybody around you can be well prepared for any disaster. Is this going to be a single step solution? Well, there is a single step solution mainly through history taking. So if you take history properly, you might get most of your answers that you're looking for. So you might get whether the patient has comorbidities or whether they have had similar episodes in the past. All this can be gathered from history taking, and they're almost always emphasize. When you go into your, for instance, I see a lot of third year dental students. I don't know whether they have medicine in their curriculum now, but when I was in third year dentistry, we had a subject called general medicine, and our general medicine professor would emphasize history taking so many times that it got ingrained in our minds that, okay, history taking is very essential. However, everybody lies. I know if somebody is interested in watching Dr. House, they would know that how he overemphasizes this point that everybody lies. They don't tell you the truth. You might not always get the best answer from the patient, but there are ways in which you can probe into these patients. And I would think the 5 crucial questions, by no means this is an exhaustive list. This is not everything, but the 5 crucial questions would be, how do you feel today? Sometimes you might have a patient, and this is a live situation. This is an actual situation, not a live situation, an actual situation where someone came in, an old 65-year-old man came into a clinic. He was puffing and short of breath by just climbing 1 fleet of stairs. So the entry was at the basement level, and it was just an elevated area for the clinic. So just 5 or 6 steps, right? So he came to the reception. He was puffing for that, and very sweaty on a normal wintry day, not almost 26 degree day. And he was puffing, and the receptionist said, okay, you have an appointment, you're late, please come in. And he went on and sat under the dental chair. The dentist, who was an astute dentist, he was very alert. He said, how do you feel today? Do you feel all right? It doesn't look like you're all right. You're sweaty, you're short of breath. He said, yeah, I'm just not feeling okay. I don't know. I have this it's not my best day. So he said, okay, in that case, I don't think this is the right day to do your treatment. It might just add to your stress. You might have something, might as well go home. He insisted no, but the doctor was very firm in his decision and he did not go ahead with the treatment. The next day, someone told this dentist that patient died that very evening. Had that patient gone ahead with the treatment, had that dentist done the treatment, the dentist would have been responsible for it. So it is a fortunate escape. So a simple question like, how do you feel today? Just understanding what is it like. We are all going to be busy practitioners, but these are crucial questions. Don't miss them. find out whether they have medications and allergy. Sometimes you can ask them, are you diabetic or hypertensive, or you have thyroid disease? They will not know it. Our patients don't know it, but they will definitely have a set of medications that they take, and they will put all the medications in front of you. If you're not familiar with the medications, which might be the case because pharmaceutical companies change the trade names, brand names all the time. So you just take the list of the medications on the day when you see them. Do not do any treatment, and make that your homework. So when you go back after that, instead of seeing it in front of the patient, what the medications really are, you can actually do it as a homework and check it in the background what the medications are. So you know the medications, your allergy, whether the patient is allergic, all through that checking what medications the patient has. You can always ask patients whether they have had any surgery in the recent past. So you'll know whether they have any severe condition which needs knowing, or if they've had any hospitalization in the recent past. So these are small questions. The most important and the relevant question here would be to ask if they've had any previous dental experiences. And this is mainly patients who appear fit, but they might have had some problem during the previous dental experiences, as simple as anxiety, and if they've changed their dentist, for instance, and that you can see that they have had some dental treatments in the past, and you're suspicious, and why have they come to you now? Because normally once they find a dentist and they build trust, they will continue to work with the same dentist for a long time. And now they have now come to your clinic. So is there a reason? Have they just relocated, or is there a reason why they changed the dentist? So that you just find out it. You don't have to criticize the dentist's work. You don't have to say that yes, there is bad work in your oral cavity. That's not something that you need to do. But I think you can see if they have had anxious moments in the dental setting, then that would be your cue and how to manage it. Because almost all the problems that you will encounter in the dental chair are preventable. Of course, when I say all, with the caveat that there are some problems that, but just due to bad luck, can happen in your dental clinic, and you will not have the time or the expertise to handle it. But 95 to 99% of all medical problems can be handled as a preemptive. When I say preemptive, if you know what you're looking for, you look for it, you identify it, diagnose it, and treat it. So anticipation, like I said, and preparedness is the key. So what do you do as a dentist to be prepared? I would emphasize that you have an emergency drug kit. Now, this drug kit should be checked from time to time, and there are only 7 drugs to be kept in that kit. You can keep an 8 if you want to, but I will describe the drug list for you. And that drug list should be checked from time to time, just to make sure that you don't have expired drugs that would cause medical legal issues. You need to know a good general practitioner in your vicinity. It can be somebody you are related to you, your family member, a good friend, for instance, who was in your school has now become a doctor, or just your neighborhood doctor. But you have to speak to this doctor first as a dentist and find out if they are capable and happy to be of help if there is a medical emergency. Not just to write a referral letter and to ask them, fit for dental procedure, fit for endodontic procedure, fit for extraction, all these things. There is no need to just keep doing clerical work. You have to try and build a small response-based practice where your neighborhood doctor, and he will not only be your referring doctor, but he'll also be your doctor who can help you in times of trouble. So these are important things that you should have in place before there is a problem, not after. So you need to have your ambulance contact number ready. You should know your ambulance local service number. So for instance, in Karnataka, there's a 108. I don't know whether the same service exists in other states, but you need to find out the ambulance number. Also, you need to find a hospital nearby whose emergency services are good. So if you have an ambulance come to your clinic, you should tell them where to take that patient. It is so important because a lot of time ambulance guys, especially in a country like India, I'm not very tuned to the work that is there in India. Of course, I practice predominantly in India, but because I have trained outside, I'm so spoiled by the nature of healthcare that they have. But now when you look at it, I know that there are some loopholes in our healthcare system. Like, for instance, the ambulance guy might take the patient to a nursing home kind of a setting because he might be getting cuts from that place. And without knowing the emergency situation, the ambulance person might take them to a smaller hospital. So if you are in charge of that patient and the patient is going from your clinic, a life is valuable, and think of it as somebody, you from your side, from your family, from your relative being in that situation and going to a wrong place for primary emergency care. And that is why communication is a key. You should have these data in advance. So you should know exactly where the emergency services are available, where they can do anything that is required, and you keep these contacts in advance, not when there is an emergency. Keep them ready, and I trust me, you will never have a situation where there will be an emergency. Preparedness is one of the answers to keep this. Sometimes you find interesting things in the patient's purse or pocket. So, you can ask the patient, do you have an EpiPen? The EpiPens are not very popular in India, but we have people who do have EpiPen when they can afford it. It's basically only an injection, an epinephrine injection for an anaphylaxis, where the patient is allergic and gets severe anaphylactic reactions to, say, for instance, a food substance that they eat. For, say, a lot of people are egg allergic. So I know people in Bangalore who have this kind of a EpiPen, and they keep that with them all the time. So okay, fine, this patient is allergic to something, has an EpiPen, but just by seeing something, or you say, the most common Asthalin inhaler, that the patient is asthmatic, ask them to bring their inhaler with them, not to keep them at home. If they've come for a dental clinic appointment and the patient is asthmatic, has had asthma episodes in the past, why not carry the inhaler along with them? Sometimes, they're apprehensive about the dental care procedure. They forget everything. Sometimes they forget money and come to the dental clinic. That's a different story altogether, but they might forget their main drugs that they carry all the time. And when you ask them, they should have them with them, because this is something that they don't go out without. They always carry it with them, but they have managed to come to your clinic without it. So you should reinforce the fact that yes, this is needed. However important the procedure might be, even if it's a full mouth patient with a good crown and a lot of ceramic work, which is going to give you your New Year's Eve bonus, you want to make sure that it is as safe as possible. So sometimes you might get confused when you look at an inhaler. It might look like the inhaler on the left, which is not efficient in an emergency situation. So you should have some basic knowledge of what the inhaler is. So you ask the patient whether you have an inhaler, and the patient will show you a green inhaler, whereas actually speaking, in an acute situation, only the blue inhaler will be useful. So how do you combat that? That is why I said, always try to do some homework. When you find out drugs that you are not familiar with, you can always try to find out what is the indication of this drug. For instance, let me tell you here. Now, if you see a green inhaler, it is for a long term. So to reduce the inflammation, to make sure that the patient's, lung capacity is improved by just reducing the inflammation, and that is where it is useful. Whereas this is a bronchodilator. The salbutamol is a bronchodilator. So in an acute attack where there is bronchospasm, you want a bronchodilator and not a steroid. So these are the small things that you will learn. And I know there will be students here who will be listening to this, and they just want what is relevant in their exam. But like I said, I'm not somebody who wants to give all the information for an exam point of view. I would rather want you all to be good clinicians out of this. So this will benefit you all, by just stimulating you to be curious. You might be able to do this well in your practice. So the greatest enemy of knowledge is not the lack of it. It is the illusion of knowledge. So it's, I love this quote. I really love this. It has helped me in many ways beyond what I can perceive, because this has helped me to go ahead after whatever I did to continue, pursuing more degrees. It's not these fellowships that you can get over a weekend course. It's a fellowship which involves a 365-day commitment, and having done all of that, I know why I did that is because I always thought that I'm ignorant of this subject, so I need to know it, and I was aware that I don't know it, and that helped me gain more experience, having worked in 3 different continents altogether, gaining knowledge from different hospital settings, different mentors. It has helped me fortify. It has helped fortify my knowledge, not just of the disease or defect, but the patient completely, as in to be able to provide holistic care. And that, I think, is the key. As even if we, whatever spectrum of work we do, we are now trying to make sure that at the end of that drill, if we are holding a drill in industry, is the patient and not a tooth. And that's where this knowledge is so important. So let's prepare a small kit. Now, like I said, we need to make an emergency kit. This image I took from the internet, from a website called Health First. It was so beautifully done. And this information is freely available on the internet. Like emergency medicine related pertaining to dentistry, there'll be plenty of resources on the internet. It is so easy to get that knowledge. It's that we are not looking for it. If we look for it, we will get all the answers that we need. So how do you prepare your kit? What are the drugs you need? You can take a screenshot of this, but I would say epinephrine. So basically, in a situation that there's anaphylaxis or a severe allergic reaction, you need epinephrine. You can have nitroglycerin, which is a coronary artery vasodilator. So if there is an angina, for instance, if you give nitroglycerin, especially through the sublingual route, you will have immediate relief. You can have ammonium inhalants. Now, ammonium inhalants are just stimulants. So if the patient is going into syncope, for instance, you can give them an ammonium inhalant. You've seen these movies where they use their footwear, for instance, the stinky socks. It works, but you would want to use something more medicinal or scientific. Or you can use what the other thing that in your kit you need an salbutamol or albuterol. So salbutamol is a bronchodilator. So again, if you have a bronchodilator, even if the patient has forgotten his or her bronchodilator, you can use the one which is there in your medical kit. And diphenhydramine is an antihistamine. So again, for smaller allergic reactions, not life-threatening, which require epinephrine, for instance, you can use an antihistamine. Or you can, you need to have some glucose. You can have some candies. Having a glucose, medical grade glucose would be important for patients who are diabetic. And it is such an irony. You would think, why diabetes? I will explain it later. But diabetic patients, because of their medications, are more prone to hypoglycemia. Imagine yourself as a diabetic patient who's going for an appointment. You remember to take your medicines, but you forget to eat your food. Your medicines were designed to combat your balance, your glycemic index based on whatever you're eating and what your diabetic status is. But you've now forgotten your intake of glucose. You reach the dental clinic, you're hypoglycemic because the diabetic medication has acted, but you don't have any food in your system, and you then have signs of hypoglycemia. I will discuss that later. And again, you can have aspirin. For instance, if a patient has myocardial infarction, it is not uncommon, but this is being equipped. So you have to have these things in your arsenal to be ready for any emergency. So like I said, again, epinephrine is life-saving. This one drug, along with, I think, oxygen, should be in your clinic at all times. I know when I say oxygen, 99% of the dentists would not have oxygen in their clinic, which is wrong. And this practice should change, because I will tell when I discuss oxygen, I'll let you know about that. But epinephrine. Now, epinephrine can be kept in an EpiPen kind of a format where it is easy to deliver. And you should, again, if I show you the EpiPen here, I will go back. you need to know which side is the needle end. A lot of times I have seen young trainees, when they get an EpiPen, they put the blue part on the skin, which is wrong. So when you are in a panic situation where when you're not prepared and you don't know what an EpiPen looks like, you will take and you will try all sorts of things to get the EpiPen injected into the patient. But if you know where the needle side is, which is the orange side is the needle, you keep that orange side along the anterolateral thigh, and then you press the blue, the needle will deliver the epinephrine. So there is an easy uh, dilution of an epinephrine that you need to remember, that is 1 in 1,000 for patients who are more than 30 kilos, or if it is less than 30 kilos, that is mainly pediatric patients, you can have dilution of 1 in 2,000. In fact, there is such a beautiful drug that it doesn't have any contraindication. Suppose a patient is not anaphylactic and you give the epinephrine injection, it will not cause a lot of harm. So unless of course you keep giving the epinephrine, but if that is why having an epinephrine injection is important. In a patient which is similar allergic reaction, but it is not life threatening, that is where the histamine blocker comes into place. You see some itching, hives, rash, and if you don't have an histamine antihistamine or a histamine blocker, then the lack of that would be distressing. And if you give an antihistamine, the effects of these drugs are very instantaneous. They're fast onset drugs, so they're very good in cases where it could stop an entire procedure, and it will also highlight the unpreparedness of the dentist. So these are the things, these are reasons why you should have them in your arsenal. Now, like I said, I came to oxygen. Now, oxygen is a beautiful drug. It is something that I should not be calling it as a drug, because it is a requirement. As everybody knows how crucial oxygen is. Of course, the level of oxygen in our daily life is now dwindling because of the pollution, and we're not able to get good oxygen. And that these are good air, for instance. It's wrong to say good oxygen, but in an emergency situation where you want to deliver oxygen into tissues, the best thing to do is start oxygen at 5 to 10 liters of oxygen, 15 liters, and sometimes when the patient needs more delivery. So it is you have very handy cylinders. It can be very sleek, aesthetic. You can keep it in a corner of your dental clinic, and all that you need to make sure that they're non-leak, non-leak cylinders, and cylinders which have to be actually checked from time to time. But if you don't use them, they kind of get they get empty very soon if you don't use it, which is why most dentists don't think of investing in a cylinder. But if you get a good anti-leak cylinder, you will still find enough oxygen in that cylinder in a situation of emergency. So I think as a protocol, going forward, whoever is listening this, at least 100 people out of 100, if 70 keep an oxygen cylinder which comply to the norms of keeping an oxygen cylinder in the clinic, it will make a world difference, because it might not always make the patient better in a situation where you need to do more, but it will never make them worse, never. So I think it is important. So my wife is an orthodontist, and when she started a clinic, I emphasized that she has oxygen cylinder in the clinic, and she never understood the reason for it, but I had to explain it. Being my spouse, she agreed, but a lot of other friends have never taken seriously my advice. Remember, we are all going to practice for a longer duration. To think that we will never have a complication in, say, 30 years of our practice, that is just playing ostrich. We need to be prepared. In the 30 years, you might have one complication. That one complication can happen in your second year, can happen in your 30th year. Based on where it happens, it can make or break your career. So you have to really, really think about it. It will always break your career, trust me, if you have a complication, because if you're not prepared. The only place where I would not want to give an oxygen is in patients with hyperventilation. I'll explain why that is important. Just give me a minute. Sorry. Right. So, there, like I said, on the internet, there are many resources that you can use. There's a beautiful poster by the British Dental Association. In fact, the British Dental Association has made it freely available for everybody to access it. And you can actually print these posters and keep it in your clinic for you to refer. I know we kind of have this culture that you need to know the drug, the micrograms, the calculations, everything, and you kind of try to remember or memorize these things, and when actually required, you forget them. You can only remember till the exam, and you can write it in your exam, and when it really matters in real life situations, you're like, oh, okay, I don't remember the drug, nor do I remember the strength of the drug. So these are things that you don't need to remember, because there are so many things to remember now, especially with your minds have diversified, and you're not just thinking about the subject, but you're also interested in many other things around the world. And it is good to be a jack of all trades nowadays. It's not, you don't have to really just do dentistry all your life. You can be an artist, you can be a dentist alongside of it, you can do so many other things. So your brain is occupied all the time with various things. To remember some milligrams is not possible. So I would think it would be good to have a screenshot of this, or go to the internet and find these posters. Just print them out, keep it. Of course, for an exam going perspective, you will need them, and you will have to memorize them. But each drug, say for instance, adrenaline, aspirin, glucagon or glucose, for instance, or glycerin trinitride with the GTN, midazolam, bronchodilator, where they are indicated, what is the strength, how do you give it to the adult or in pediatric population. It's just one slide and explains it all. And when you come to the resuscitation bits of it, everybody says ABCD, airway, breathing, circulation, and diagnosis, or distress management, or whatever that D would stand for. I would think I would use D for definitive care. And I also like to add P, position, because a lot of times, say for instance, if there is an epilepsy, you don't know what position to put them in. We all know for syncope what position to put in, and I'll come to that again, which is again not very standard. But for instance, if the patient is having an epilepsy, should you reposition them? Is the dental chair a safe enough position for them to be in? So you have to really think about position as your first point before you do anything else. Then you can check the circulation. So you basically check pulse. And I think as dentists and students, especially now that you're students, please, whenever possible, try to check the pulse of the patient. It would not mean anything. You will not get anything out of it. But recognizing normal is very important. As a lot of dental students miss this. They go from clinic to clinic, seeing multiple patients. They might see 100 patients in different specialties, say for crown cutting, for exodontia. At least in exodontia, when you're posted there, why not try to check the pulse? Because you want to feel normal. You want to have the muscle memory. This is just there is a lot of detail in the way our body functions, and we need to know it. So we need to check the pulse and feel what normal is, and then we will be able to say, okay, this patient does not have a pulse. But if you never check the pulse, which even my postgraduates sometimes when they come here and I ask them to check the pulse, I'm appalled at the way they can't really find the pulse. So I think we have to learn these things, because these things will only be learned when you're very young. You're in a very good position to learn these things. And once you identify it, once you learn it, it is just like riding the cycle. You will never forget it. And airway breathing is another point that you need to make sure when you're looking at doing the basic care for a patient. And like I said, definitive care, you need to know what the differentials would be. You need to understand what it might be. And if you need some drugs to look after it, or you do need a defibrillator for it, I will tell you that it might not, you never need a defibrillator in a most, you should be really, really unlucky to get into that. So coming to the first emergency. Now, this is not an emergency if caught early. So syncope, we all know, is a sudden attack of vasovagal attack where you fall you faint and you fall on the ground, and suddenly when you're on the ground, they'll take you and put you into a chair and put you into a what is called the Trendelenburg position, because the name is so attractive. But in all honesty, that position is not an absolute must. I know a lot of teachers, professors would still say Trendelenburg, but and the modern research does explain that you don't have to put the patient into Trendelenburg. There is known to gush the blood into the cerebellum and make it, perfuse the cerebellum, but rather just have them supine, elevate the leg or flex the leg. So for the benefit of the students, I will explain what happens in a syncope. Yeah, you are stressed, you're scared, your body prepares for a flight fight response. So consider this, which is a very common example. You're in front of a wild dog. Yeah, I'm using dog as an example, whereas Guyton shows, I think, a lion as an example. But if you're in front of a wild dog and you can see, it's a rabid dog, and the only thing that you now know is you have to run. You have to run for your life. Now your mind has sent signals to your body and has prepared your body for a flight response, which means your skeletal muscles should now receive all the blood circulation, because nothing else needs blood. Your stomach doesn't need blood, your brain doesn't need blood, nothing else needs blood, but your muscles, your skeletal muscles require blood, right? So blood has gone into your skeletal muscles, and now you run. And when you run, because the bloods are because the muscle is well perfused, you can run, and your skeletal muscles look after you, and you're away from danger. The same danger principle is on the dental chair. You're sitting there, you're afraid of these needles, you're afraid of the dentist. The dentist is not, smiling. He comes with this gas mask post-COVID, and he looks down at you, and you're like, oh God, what's going to happen to me? And you're ready to fly, fight, or, in your fear, you want your body to take you away from the dental chair. Blood has gone into the skeletal muscles, but here the skeletal muscles are not moving. You're not actually running. Your mind wants to run, but you're not running. So blood has now pooled in the periphery. That's what they say, peripheral pooling, right? Now, because of the peripheral pooling, there is lack of cerebral perfusion. So that means you're now in a vasovagal syncope. That means now you are going to faint. So you start having this pre-syncopal, dizziness, blurry vision, blurry speech, and all, and you faint. When you faint, you fall down. When you fall down, there's an activity, or if you're on a chair, you just syncope. And that is a time when if you identify someone with apprehension and with dizziness, just ask them to flex their legs. Keep flexing the legs up and down. That before the syncope has set in, he is now actually moving his skeletal muscles, so the peripheral pooling of the blood is not happening, and that is why he is not going into syncope. So that is where you identify risk. You identify this. So that's why they say, apprehension, stress. These are the things that you need to pick up early. Let's not be dentists who think that a dental experience is all about, giving them trauma and not being the friendly person that you can be. We are also jovial beyond it clinic. We even if we are in rush and we are in a hurry to finish the 10 patients that are there in our today's appointment list, I think we need to give that care to all our patients to make sure that they are nice and calm on the dental chair, so that we can prevent most of the things. So the pre-syncope would be, feel faint, dizzy, light, collapse. There'll be loss of consciousness. The patient will have pallor, sweating, a slow pulse, low blood pressure, nausea. So basically, just stop the treatment, lie him flat, elevate the legs, flex, ask him to flex if the patient is responsive. You can loosen the tight clothing. Again, you'll have to probably maintain gender bias in that. So be mindful of what you do. Always have somebody else in the room to make sure that, whatever you do is tested, right? You don't want to do anything that can cause any medical legal concerns in your thing. And consider oxygen. In most cases, the patients revive instantaneously. You may not have to give any oxygen. And once the patient is awake, you can offer a glucose-rich drink once they're responsive. Hyperventilation. Now, hyperventilation is also very common. Unfortunately, without having a gender bias, it's more common in women because they feel that puffing, hyperventilating is is going to be more relieving. But actually, what is happening is so how do you identify hyperventilation? It is basically they are breathing rapidly, but they're shallow breaths. So when you're shallow breaths, you're not sending enough air into your system. So you're basically exhaling more than you're inhaling. So this is all anxiety induced, right? So anxiety has caused hyperventilation. Now there's increased expiration of carbon dioxide. Yeah, so now you have hypocarbia, that is less carbon dioxide in your system, and that will lead to hypocalcemia. So there is symptoms of hypocalcemia. So whatever you see after hyperventilation and hyperventilation, so you basically just less intake, exhale. So you keep on exhaling and you're chucking out carbon dioxide from your system. So what are the clinical features? The patient is anxious, breathing rapidly and shallow, and then can complain of some tingling sensation, especially in the perioral area. And you would think that is this my local anesthesia, but no, it is actually the symptoms of hypocalcemia, that perioral tingling, or sometimes you can have tingling in your extremities. And in very severe hypocalcemia, they can go to carpopedal spasms. And this is very, very severe amount of hypocalcemia. And some patients can feel lightheaded or breathless and occasionally faint. What you need to do in this situation is basically reassure. You can ask them to actually breathe in expired air, so which is carbon dioxide rich air. So you just ask them to put a paper bag, not a plastic bag, otherwise they can choke on that. So these are small errors. All this can happen. A lot of people, when I say bag, they would just go and fetch a plastic bag. So these are not things that it seems so dumb sometimes when I explain it to people. It's like, who would give a plastic bag? But that has happened. It has happened. So because you might not have a paper bag. You see, it is very easy to put things on a slide, but in practical reality, when it is real life situation, all these are reflex situations because the person is not prepared. They're panicking. The first person who should not panic is the dentist. Once you panic, you'll make wrong decisions, and these wrong decisions will cost a life. So I think we should not panic. Of course, we can always tell our patients, we should not panic. But I think we are in a situation where there's something which is unfamiliar to us happening, and we kind of get panic. So that's why familiarity. Remember when we just started this presentation, I always said, the preparedness is the answer to most of our problems. So anticipation and intercept. So the next problem can be a stroke. It's just so common actually that old people, especially hypertensive patients, can get stroke. So what happens in a stroke is basically they can have an intracerebral bleed, and because of the pressure of the bleed, they can have a stroke, or they can have nervous stroke. So there are many ways of stroke. I will not get into the pathophysiology of a stroke, but how do I identify a stroke? You can see a facial weakness. So when this patient is smiling, it is asymmetric. Differentiate that from the effects of an anesthesia. In an anesthesia, you don't get that kind of a drooping, whereas in a stroke, you will have the typical, almost paralysis. So all those who have seen Guru Bhai, for instance, you can see that, oh, he had a stroke. So that is what it is, right? He could not, there is arm weakness. So you can't, when you ask them to raise both hands, ask them to do both hands because you want to see the difference, right? If both hands cannot go up, it is just basically a generic strength or disability. If it is asymmetric, you can pick up asymmetry better. Or if the speech is unclear, again, stop treatment. Make sure that you give oxygen. And I would then think, do not offer water or anything to eat.
त्यांचा नंबर आहे ना तुझ्या बोर्डवर मोबाईल नंबर
because it might be an unsafe swallow. So it is best not to give any patient, the patient who's having stroke, anything by mouth, because you don't want them to have aspiration. So when I say unsafe swallow, if you give something to a patient who's having stroke, it might just enter their larynx, and you don't want that. And again, it's an emergency, call the ambulance. If the patient is having an epilepsy or a seizures in the dental environment, now what can cause seizures? Basically, most epileptic patients will always give a history of epilepsy. It can be associated with stress. Can be because of cerebral hypoxia or in a syncope with inadequate airway, they can have epilepsy. It can happen in patients with hypoglycemia, or it can happen with local anesthesia overdose. So these are different types of seizures, but it is important to identify that. But one thing is very reassuring, that seizures have a time limit. Once the time is done, the seizures stop, irrespective of whatever you do. So what do you need to do when the patient is having a seizure? You can identify it early. How do you identify it early? You can, in patients who have seizures, right, who are non-epileptics, you can ask them, is it associated with aura? So what is aura? Aura is a typical sign. So they can see something, they can see flashes of light, they can hear something, they can smell something, which is not actually present, but they feel that. So take that history from that patient, because if the patient says that I have epilepsy, or is it associated with aura? He said, yes, I can always feel this ringing sensation in my ear before I get that epilepsy. Okay, now when you're there in the dental setting, and he says, doctor, something is ringing. This patient is now going to have an epilepsy. You cannot stop it, but so you remove all the things from his mouth, make the patient comfortable in his chair, and that's preparedness. You are now prepared for an epilepsy that is going to happen because you've picked up on that aura sign that he gave you. Yeah, you cannot stop that epilepsy from happening at this point, but you have enough time to safeguard him or her and yourself, right? So if it is related to a local anesthesia overdose, it is usually for 1 minute, and it peaks and then drops down immediately after 1 minute. If it's a grand mal, it is never beyond 5 minutes. It can be from 2 minutes to 5 minutes. So the ictal phase, the real tonic-clonic shaking phase, is not even for a minute. Then there is a post-seizure phase, and that is important to identify. Once the jerking and everything is over, you need to make sure that the airway is safe. So sometimes because of once the jerking is done, the tongue will fall back and compromise the airway. In that condition, do not put anything in the mouth. Remember, you don't want anything. You need your fingers for a good practice. So you don't want to put anything into the mouth of an epileptic patient, but you can give a jaw thrust. Yeah, if you give a jaw thrust in a post-ictal phase, so after the seizure is over, you can give a jaw thrust to make sure the airway is patent, because otherwise you'll hear the snoring of that patient, and that their airway is not secure. So again, positioning. So PCABD, in that positioning is the most important. You can position the patient on the dental chair itself. No need to bring him on the floor or anything. Just make sure on the dental chair, support his side so that he doesn't fall off the dental chair. Make it supine. You can put the patient on a lateral position if you like, because if there is vomiting something, then you don't want them to aspirate. Yeah. Otherwise, you don't need to do anything. Make sure he's safe from all the other equipment. Especially we have sharp drills, we might have some elevators, things that will fall, there might be some x-ray arm sitting right next to him. You can keep all that away. Make sure that everything is away, that patient is away from any danger. This also note the time when this seizure started, because you need to know that you can't, 1 minute will feel forever. Trust me, when you have a patient seizing in front of you, that 1 minute will be the longest 1 minute of your life. So make sure you note the time. You can actually ask the attender that how long does it happen? Does it happen often? And if it happens, how long does it last? They will have much more idea than you. Trust me, patient and the patient's attender are more knowledgeable about that medical condition that they have than you have at that point. So always try to take more from the patient. Give them the benefit of doubt. Tell them that. You don't have to always look inferior when you take all these details from the patient. So you can always make the patient feel superior in the knowledge and take all the knowledge that you want from them. That is one way of learning about the disease, one way of making sure that they know exactly how to be prepared. You can give oxygen at that time, and also if the seizures goes beyond 5 minutes, then you can give a drug called midazolam. So you can have that prepared. You know exactly, and you can give it IM in an anterolateral thigh. You can inject some midazolam. After the seizures is over, you can give the patient some sugar, because he has spent energy, so he will feel wasted. So might as well give some sugar after the procedure. Talking about sugar, I think hypoglycemia is a good condition to take. It can, hypoglycemic patients can mimic a syncopal attack. They usually have a history of diabetes. they get lightheaded, they have pre-syncopal symptoms, their extremities become cold, and they have mild tremors. So how do you, what do you do? Stop the procedure. Give some glucose or candy to suck on, and you can actually see the reversal of symptoms immediately. I don't think you would be well equipped to start a 25 to 50% dextrose IV, but if the patient is unconscious, you should be able to do that. And I will tell you in my last slide why and how you can do all of that. Again, coming to another condition like an adrenal crisis. So if a patient has been receiving steroids for a long time, what happens is the adrenal gland atrophy. They do not make enough cortisol for that patient. So there is, especially during the evening time. So morning time, there is peaking of the cortisol. By evening, the cortisol levels are going down. And in a condition, yeah. So in a condition where you want to do that, just 1 minute. Sister, Madhuri? So if the adrenal gland is atrophied, my train of thought is interrupted once in a minute. Okay. So if there's atrophy of the adrenal gland, so it will not produce enough cortisol to combat a stressful situation, and a dental appointment can be a stressful condition. So that is where the cortisol levels are not enough, and that would cause all the conditions of an adrenal crisis like collapse, pallor, cold and calming skin, hypotension, dizziness. Again, the management is nothing extraordinary, but just positioning the patient and providing oxygen. In a patient with cardiac anomalies, for instance, you would identify a cardiac emergency by symptoms of tightness, heaviness or pain in the chest, pain that is radiating to the neck, jaw, shoulders. If there is pallor and sweating or breathlessness. And what you need to do is position the patient. Usually they're comfortable when they're sitting up. You can use a GTN spray or a sublingual tablet. You can crush or give a powdered form of aspirin so that there is, so you have an anti-hemolytic there. In a severe condition, you can give an AED, which I will explain. So for anaphylaxis, I think the most important signs and symptoms are urticaria, respiratory distress, stridor, hypotension, and tachycardia. Right, somebody's cleaning the vessels along with this.
Dipesh, can you make me host?
Yeah,
I will mute them.
Sure, I will try.
Nick Arnold, please mute your audio.
How do I make you host now?
That security is there, yeah. Or you can go on the participants and make me host.
Yeah, making you host.
Yeah. Thank you. Yeah.
Yes, I'm so sorry. I just yeah. So we were on anaphylaxis. So the management for anaphylaxis is basically make sure the airway is secure. Again, oxygen plays an important part in the management of anaphylaxis. And the life-saving drug, again, repeating, life-saving drug in anaphylaxis is adrenaline. So you can give a 0.5 ml of adrenaline of 1:1,000 dilution IM into the anterolateral thigh. So like I said, you can use an EpiPen, or for instance, you can use an adrenaline formulation, and this would help taking care of anaphylaxis. Sometimes in a severe anaphylaxis, you might have to repeat the drug. So only in those situations, you can give another dose after 3 to 4 minutes. But I think in most conditions, you will be able to get away with 1 or 2 injections of adrenaline unless and until it's a severe attack of anaphylaxis. like I said, an asthma can be prevented by being prepared. You know a patient is asthmatic, try to give them an early morning appointment, ask them to bring their bronchodilator along with them, try to make this procedure as stress-free as possible. Do not, you have to identify it by if the patient is having difficulty in breathing, if there's wheezing, if the in a patient with silent status asthmaticus, this is one of the questions you can ask in Viva. There's a silent chest because of severe bronchospasm. Because of the amount of bronchospasm, there's no rhonchi, or there's no wheezing, because the bronchospasm is now very severe. There's no air entry and exit. This is where status asthmaticus can be life-threatening. So that time you can have signs of hypoxia, including cyanosis. So the treatment there would be giving patient bronchodilators. If it still persists, you can give an IV bronchodilator, oxygen. And for the benefit of the patient, students, management of status asthmaticus is as severe as the condition. It is oh shit. So oxygen, salbutamol, hydrocortisone, ipratropium bromide, and theophylline. I know these drugs will not be required in your dental settings, but it is only for the status asthmaticus would be one of the things that can be asked in your medical exams. So you need to know these drugs, and you need to know the strengths that in which you will give these drugs. Basically, what are the precautionary situations? Like, for instance, if a patient is on an anticoagulant drug, you take a classical history that the patient has had cerebrovascular accident, there's a history of smoking, elevated cortisol levels. So these patients will be on anticoagulant therapy, and you need to, if there is a history of infarction, for instance, you need to know that these drugs are anticoagulant drugs. So that means they're on warfarin or HMG CoA reductase inhibitors. They might have diuretics. So they might have a full battery of antihypertensive drugs. And there might be somewhere, there'll be a warfarin in that list of drugs. And that's where you pick it up. Okay, so if the patient is on medications like for antihypertension or some after, for a cardiovascular disease, and there is an anticoagulant in it, then you know that this patient will be more prone to bleeding. So you can actually do an INR test, which is important in anticoagulant therapy. Or I'm talking about all the lab tests that you might need to do in a bleeding patient. For instance, you can do a PT or a PTT. So you can do BTCT, that is bleeding time, clotting time, or a prothrombin time, and a PTT test, or an INR. Now, INR is mainly related to the anticoagulant therapy. So the normal of INR is 1, but in a patient for requiring minor extractions or minor oral surgery, even 2.5 to 3 is an acceptable INR, making sure that you have local hemostatic measures available. So you have to first minimize the trauma. You should be able to do a good closure. You should be able to have these bone wax, cellulose, collagen, gel foam, all these things in your clinic, which is mandatory. Every dentist should have local hemostatic measures in their things in their clinic. And you can give an antifibrinolytic drug like a tranexamic acid. Basically, just take the tranexamic acid vial, break it, wet the gauze, and ask the patient to bite. It will stabilize the clot. It will look after your bleeding even in conditions where there is unexpected bleeding post extraction, for instance. Of course, we have to make sure that all the basics are taken care of. That means the tissue is nice. It should not be very tethered. So you can use a tranexamic acid vial and wet your gauze and ask the patient to bite. If the patient has had cardiac surgery, all these recent bypass surgery, don't do any elective procedures for 2 to 6 months. You don't need an approval from somebody to do a procedure. Just don't do it for the next 6 months. If there is a necessary procedure, at least give an 8-week window. And you can always ask your cardiologist if there is, it is safe to do it. But necessary procedures can be done 8 weeks after the bypass. But elective procedures, you can easily defer. Try to give early morning appointments. Make sure you have an effective pain control, and that can only be done with good local anesthesia. So when I say local anesthesia, everybody says local anesthesia with adrenaline. Can we give local anesthesia with adrenaline in these patients? Yes, you can. You can give in most patients. You can, and you have to just make sure that you aspirate multiple times. Make sure that the injection is slow. Limit your administrations to 3 ml. Don't give too much local anesthesia. If you want to give more, if your block has failed, at that time, just make sure you give a plain local anesthesia, because your adrenaline is giving your effect of vasoconstriction. but you don't need more anesthesia effect. I don't know whether you got my point. So if you give a local anesthesia with adrenaline first, yeah, that is say 2 ml, and then you check, okay, it's not working. My anesthesia did not, my block did not work well. Now, when you're supplementing in these patients with comorbidities, supplement with a plain anesthesia because you're not overloading, but you've got the effect of vasoconstriction, but you're not got the effect of local anesthesia. So you are supplementing with a plain LA. So yes, I know there is an apprehension of using LA with adrenaline in a teaching setup where you will be told not to give with adrenaline in patients with comorbidities, which is fair enough because you don't know how many times you will be injecting and how much ml you are going to inject. But in a practical setting, yeah, if you want to make sure that the local anesthesia stays there for longer duration, so that your duration of local anesthesia is longer, so that your pain cover is longer, and there is vasoconstriction, so it's a bloodless field. All these are important points. So you will give it up to 3 ml is safe. So you can give your block, and then when you're supplementing, give a plain. So it is safe. If you have time, go through this article in the Journal of California Dental Association in 2000, where they printed a list where you can use, where you should avoid vasoconstriction. So, for instance, in a patient with propranolol, a non-selective beta blocker, you avoid vasoconstrictors because what happens in them, it is an additive effect. So there is extreme vasoconstriction because of your local anesthetic vasoconstrictor, that is adrenaline, and the propranolol. So there is extreme vasoconstriction which you don't want. So they can have an increase in pressure. And again, if a patient is on digoxin, you want to avoid a vasoconstrictor because they might have arrhythmias, so you don't want that to happen. In a patient with pheochromocytoma, for instance, which again, all that you know only via history, you would want to avoid vasoconstrictor. Otherwise, all the other list, if you see, in most cases, that is hypertension, angina, myocardial infarction, diabetes, adrenal insufficiency, all these things, you are actually the thyroid disease, for instance, hyperthyroidism, hypothyroidism, you're not avoiding adrenaline. So you're actually just being cautious with your adrenaline. So it is okay to use adrenaline in local anesthesia. The last point I would like to state is pregnancy. Now, pregnancy is a physiological state. It is not even a comorbidity. I would be appalled when people classify it as a comorbidity. And there is a letter, an open letter by a gynecologist to dentist saying that, thank you for looking after the teeth. You have a wonderful set of skills, but for the 1,000th time, please stop writing letters to me asking for fitness of the procedure. Yeah, a lot of people try to ask the gynecologist if the patient is fit for a dental procedure, but your oral cavity procedures cannot harm a pregnant lady. You have to be aware of what is required. You need to know exactly what to do. You have to reduce the stress. You have to give adequate pain relief. You should not give counter indicated drugs to the patient, but your procedures are at no major risk. You can go ahead, do your procedures without having any problems. Of course, make sure that you put a lead apron on the mother to prevent any radiation exposure. All these things are basic. These are basic, but you do not need a gynecologist's approval to do a procedure. So there's nothing your local anesthesia can do to hurt the fetus. Penicillin, antibiotics such as your amoxicillin is safe in pregnancy. Local anesthetic is safe in pregnancy. Even narcotics is safe in pregnancy. Oral X-rays are safe in pregnancy. Just shield the baby like you would shield any patient. And if after reading this also you send your patient to the gynecologist, will really be, thinking that you're doing a disservice to the patient. So after having concluded all of this, there are two important things that I need to emphasize. And this is something that everybody, including the receptionist, the nurse, even if you have a watch guy, your driver, and yourself should be familiar with BLS. It is mandatory. Everybody who's associated with patients should sign up for a BLS course. Find a local BLS course and please sign up for the BLS course. And encourage everybody in your setting, in your dental setting, when you become dentists in the future, or as students. I think as students, the best time to do BLS is now. Sign up for a local BLS course. Let it become your newer resolution. Learn the BLS techniques. Understand what it is to secure an airway. Give CPR. You should know this. This is not something that is, paramedics, layman people sign everywhere around the world. You should be able to do BLS. And as dentists, you should also be able to do ALS, that is advanced life support. You should know, you should have the familiarity, knowledge, training that is required for ALS. You should be able to administer an IV line. You should be able to secure an airway. These are things that a dentist should do. As an ALS, you call yourself, you use the suffix doctor with pride. At least do this BLS and ALS compulsorily. Just, I don't know how you will try to do it, but I cannot overemphasize this point that everybody should be updated. Also, don't do a BLS course in 2000 is not the answer. The BLS course has to be updated. You have to keep refreshing yourself. You have to keep updating yourself with an ALS course. These are things that will be invaluable, wherever you are, not in just your clinic. If you're outside, if you have the title doctor, you should be able to address these essential problems. Assign roles in advance when you're in a clinic setting or anywhere. If there is an emergency, you should make sure that the receptionist knows that she has to call the emergency service, because you will be involved in the care. So you should have these roles well advanced. Fire drills keep happening for the anticipation of fire. The people who have fire drills are the people who survive any fire. So I think we should have drills in place. So you should assign roles in advance. Again, quick summary: an unconscious patient, can instantaneously recover if it is a syncope. If there is no instantaneous recovery, then you check for the pulse. If there is not palpable, you should give a CPR. So now you need to know what a CPR is. If it is palpable, you can give glucose. If there is no recovery, you can give oxygen and steroids. Thank you so much. Life is all about continuous learning, and we keep climbing. Thank you. I'm happy to take any questions, as many as there are.
There is one question already there in the chat box.
Yes, sir.
Dipesh, Nirpan is asking that patient is on anticoagulant and the INR is below 3 without stopping anticoagulant 24 hours before extraction. Can we proceed with the extraction?
Yes, you can. Question. Yes, you can. You can go ahead with the extraction, provided it is going to be an atraumatic extraction. For any traumatic extraction, you might want to stop the anticoagulant for 24 to 48 hours, and then you can do a traumatic extraction. If it's an atraumatic extraction, your local measures of providing a stable clot would be enough to look after it. So, but if you're going to drill and you're going to do all of that, then you might want to make sure that you at least have an INR of 2 or 2 point, I think 2. So, yeah.
Yeah. Hope that he is happy with that. Any other questions by the participants? You can unmute yourself and ask here. Yes. Yeah. Dipesh.
Yes. So yeah.
Easy asking, like 24 hours to 48 hours stopping is necessary.
So I'll rephrase. I'll answer that again. So in a situation where the INR is below 3, if you're doing an atraumatic extraction, you can go ahead and do the extraction. If you want to do, say, an extraction where you think it's going to either, you might have to do an open extraction or it's an impacted tooth, then you want to keep the INR around 2 at least, if not 1. Okay, considering 1 as normal. Now, if you come to a situation where you think that stopping the anticoagulant is important, now let's first understand why we are giving the anticoagulant. First, if the patient is on maintenance warfarin, yeah, so that warfarin is not critical to the patient, then you can stop the warfarin. When I say that you have to do an extraction with the warfarin on, it is for patients who critically need the warfarin. If you want to do if a patient is only on maintenance warfarin, then a 48-hour stopping for a platelet regeneration is enough. I know there are theories and books which says you need to give 5 days stopping of the aspirin or warfarin on an anticoagulant drug, that is, but especially aspirin, is because the half-life of the drug. 2, they also want to make sure that there is a stable platelet plug. Now, there has been a lot of debate on why the patient is on warfarin, on anticoagulant drugs, so warfarin or aspirin. So I think the why is more critical than the period. So you have to make sure that the patient is safe, right? So anticoagulation drugs is for something. If it is only maintenance, then you can stop it for 48 hours before. I hope I'm clear.
Any other questions? Okay, yeah, is good.
I just confused everybody, I think.
Yeah. Now, I will request Dr. Shailesh Menon, Professor, Nasimbai Patel Dental College and Hospital, Visnagar, Gujarat, to give a vote of thanks. Shailesh.
Okay, yes, sir. Good afternoon, everybody. It was a very wonderful and informative webinar by Dr. Dipesh Rao, sir. He has explained nicely about how to avoid medical emergencies, especially giving weightage on history taking. If you take proper history, you can avoid 99% of complications. He has nicely explained what drugs you should have in your practice, and what actually difficulties you face practically rather than having only theoretical knowledge. Nicely, wonderfully explained, sir. So I would like to thank Dr. Dipesh Rao, sir, for being with us in this webinar series, BOSS 2020. Thank you once again, sir.
Thank you.
I would like to thank all the participants from Gujarat, India, and abroad for joining us with this webinar series organized by Sakarchand Patel University, Visnagar. Thank you, sir. Thank you, everyone.
Thank you.
Thank you.